Okay, thank you. So now we move on to a topic about guidelines in the prevention and management of osteoporosis. So just aiming to give you a bit of an update on sort of current guidance and current practice. So if I'm honest, osteoporosis guidelines can be quite complicated in the UK, and that's because we primarily have two different groups that publish guidance. So we obviously have NICE, who publish both guidelines and technology appraisals for the medications that we use. In addition to NICE, we have a separate group called the National Osteoporosis Guideline Group, which is an independent group of experts that write guidance. And in addition to that, we have some guidance that comes from the Royal Osteoporosis Society, that is the patient organisation for patients with osteoporosis. So we're going to have a look at some of those. These are obviously only the UK guidance, there's European guidance and American, but I'm not going to cover any of that today. So just a reminder of what we're trying to prevent when we talk about prevention. We're trying to prevent the fractures that I spoke about earlier, the costs to the healthcare system and the cost to the individual. And the most common fractures that we see are vertebral fractures, hip fractures and wrist fractures, and along with those and humerus fractures, those are what we would term as major osteoporotic fractures. So this is what we're trying to prevent. And if we want to prevent fractures, then ideally we should be taking a life course approach. So during childhood, through adolescence, and in fact through into our late 20s, we still accumulate bone mass. So even when we stop growing, after puberty, we will be, our bones will be getting denser. Then through our bone mass stays about the same. Then for women, the menopause gives us an accelerated amount of bone loss there between about 50 and 60. And then for the gentleman, a more gentle decrease in bone mass with age that also carries on similarly in women after the menopause. So we could think, and we should think, that we want to achieve the best peak bone mass possible. And we certainly see patients in clinic who are older, but whose problem really is that they didn't achieve peak bone mass for whatever reason, be that illness or eating disorders that we'll come on to later, or other problems, maybe dietary issues, and they didn't achieve their peak bone mass. So if we take this from a public health point of view, what can we do to improve our bone health? And really there needs to be some, my personal view is there needs to be some education around this, that we need to be educating the population on what is needed for healthy bones. And certainly in clinic, I see a lot of patients who don't have a clue about any of this. So firstly, we want to make sure we have enough calcium. Our skeleton acts as the reservoir for calcium. So we want between 700 and 1,000 milligrams of calcium a day. If you're interested in that, there are some online calcium calculators that you can do. We need to take some vitamin D supplementation. In the UK, during winter months, we don't get the right sunshine for vitamin D. And in fact, the NHS guidance suggests that all of us should take 400 units a day in winter months, and that people at high risk should consider taking a supplement all the time. Our bones need protein, so we want a sufficient protein intake, and the estimates are that that should be 0.8 grams per kilo of body weight. We want weight-bearing exercise. That doesn't necessarily mean lifting weights. In fact, our skeletons need some impact. So walking, jogging, running, dancing, any of those are fantastic weight-bearing exercise. We want a healthy BMI. We don't want to be too slim and too low in weight. If anything, being overweight is going to protect us from having low bone density. Smoking and alcohol also have a part to play, and obviously those have other health problems as well. So how do we identify people at risk of fracture? And in the UK, there's no screening policy currently. There was a really interesting study that was done in the UK, published in the Lancet, called the SCOOP study. This was a screening study that looked at over 12,000 women and used FRAX as a screening tool, and they demonstrated that they could reduce hip fractures by 28%. There have been other studies done in Denmark and the Netherlands looking at similar things with similar results, and a meta-analysis of the three showed a 20% reduction in hip fractures. But as things stand at the moment, we don't have a screening policy, and therefore we're left to look for people at high risk. So the two pieces of UK guidance that help us on this are a CKS from NICE that was only published in January of this year, looking at prevention of fragility fractures. And this is an area that NOG, the National Osteoporosis Guideline Group, go into in quite some detail. Both of these are freely available on the internet. And I would suggest, if you're interested, to have a sit down with a cup of tea and have a read through them all, because there's quite a lot of detail in them, as well as the summaries. So who do these guidelines say to screen? And I apologise for the really busy slide, but just to talk you through it. So NICE say that all women over 65 and all men over 75 should be screened for osteoporosis. Their preferred screening tool is a tool called Q-Fracture that is available online, and that's what they suggest is used in primary care. They do mention FRAX, that is probably more commonly used in an osteoporosis clinic setting. Then if patients are less than 65, so between 50 and 65 or 75 for men, there's a list there of the risk factors. If they're less than 50, then steroids, untreated early menopause, which we define as less than 45, or fragility fracture. Under 40, it's really steroids, major osteoporotic fractures, or multiple fragility fractures. And there's also a list of medications, things such as aromatase inhibitors, SSRIs, proton pump inhibitors, and anti-epileptic medication, quite a long list of medications. NOG prefers FRAX as its fracture risk tool, and really has taken that stance because it can link into bone density, which Q-Fracture can't. And NOG suggests that all postmenopausal women or men over 50 who have a clinical risk factor are screened. So they take a slightly more conservative approach and don't say screen everybody, but just look at those with clinical risk fractures. And they list the ones that are in FRAX, and then also a list of clinical risk fractures, including things like a thoracic kyphosis, significant height loss, falls, frailty. There's a long list of medical conditions that won't be a surprise, but I'll let you read, and also the medications. So there is a slightly different approach here, but overall they agree on the risk factors, and they agree that we need to take a case finding approach for screening. What they do both agree on is who should be referred into secondary care. And what they say here is that anybody with a very high fracture risk, that I'll show you what NOG says that is, anybody with a recent vertebral fracture or more than 2 vertebral fractures, anyone with a BMD of less than 3.5, steroids of greater than 7.5 milligrams of prednisolone, or anyone who has multiple risk factors. So this is helpful guidance, but it has increased referrals into secondary care, and it has actually changed how I report bone density scans, in that increasingly I'm suggesting that patients should be referred into secondary care on the basis of these risk factors. So we've talked a little bit about case finding and how we're going to screen. Let's move on to think about how we're going to manage patients with osteoporosis. And I'd like to introduce you to 3 relatively new concepts. So the first is one of imminent fracture risk, and I'll define what that is in a moment. But this has made a change in that we now would consider some of our patients to urgently need osteoporosis treatments. Previously, when I was screening referrals, I would just screen almost everybody as routine. But now there are patients who I think are at imminent risk, who I think it's important to treat quickly, and I might mark them as being urgent. The second concept is those patients at very high fracture risk, which NOG has added as an additional higher banding of fracture risk. And finally, the idea that we're going to sequentially give treatments that isn't new, but the concept that we would give an anabolic or an osteoanabolic drug first, if that's at all possible. So this study from Johansson, published in 2017, helps us to think about the concept of imminent fracture risk. This was a cohort of almost 19,000 men and women who was born between 1907 and 1935, and they looked at fractures, and they looked to see when patients who'd had one fracture went on to have a second major osteoporotic fracture. They documented over 500,000 person years here, so obviously big data. The risk of the second major osteoporotic fracture was highest immediately after the first, and then it goes down, but it always remains above baseline. So for example, in the first year after, or 1 year after the first major osteoporotic fracture, the risk of a second fracture, the relative risk was 2.7-fold higher than the population risk. At 10 years, the risk ratio is 1.4, and the effect is more in older people. So this gives us an idea, going back to what I said, that there can be patients who've had a fracture, and it's important to treat them quickly because you have a window of opportunity when you're going to potentially be able to prevent more fractures. This is what I was speaking about from NOG. So when you go through the FRAX calculator and calculates the fracture risk, this takes us through to the idea of whether somebody's in the green area, where they're low risk and you're going to give lifestyle advice, in the red area, the light red, where you're going to treat, or in the dark red area, the very high risk. And NOG, and in fact now also NICE, suggests that these patients need specialist referral and treatment. And really what we're considering when we see them in clinic is, are they eligible for an anabolic therapy because they're very high risk, or as a minimum, should they have parenteral treatment? And then we have to think about which treatments in which order. So the currently approved medications reduce our risk of non-vertebral and hip fractures by only 20 to 40%, and using them for a long time is limited by waning efficacy for some of them, and a greater risk of serious side effects with longer term use of others. So for example, that is osteonecrosis of the jaw and atypical femoral fractures with anti-resorbatives. So we need to think about sequential agents for management of the patients with severe disease. So those really high risk people, we want to keep them on some form of treatment and reduce their fracture risk. And we need to understand the optimal sequence for the patient that we've got in front of us. So what are the consequences if we stop treatment, and what data have we got on different transitions? And I'm going to share a little bit of that with you. So what happens if we stop treatment? So bisphosphonates adhere really strongly to hydroxyapatite within the skeleton. And so when you stop them, they actually stay where they are and maintain largely their efficacy, probably for 4 or 5 years. There's a gradual increase in bone turnover and a gradual increase in bone density loss. Denosumab, as in contrast, has a rapid increase in bone turnover, rapid bone loss. You quickly lose the anti-fracture benefit, and there's an increased risk of vertebral fractures. And I don't have time today to go into all of that, But just to say, denosumab should not be stopped without some form of exit strategy that involves other medication. Teriparatide is a gradual return to baseline and some bone loss without giving anything else. There is data showing vertebral fracture efficacy, reduction in that through to 30 months. Romosozumab, similarly, you see bone loss, but there's no reported fracture outcomes that I'm aware of for that already. So if we stop some treatments, we need to follow on with others, probably with the only exception being a bisphosphonate, where we would consider a drug pause. So this study from Felicia Cosman is really helpful here. So she looked at teriparatide and what happens if you, in the studies where you gave an anti-resorptive first. And what you can see in all these studies where either a bisphosphonate or denosumab at the bottom was given and then a patient was switched to teriparatide, that you do not see big increases in bone density. And these are certainly very different to the changes that you see in the pivotal fracture study where patients were naive to treatment. So when we switch for anti-resorptives to teriparatide, the BMD increases are blunted compared to teriparatide as first line. What about romosozumab? Well, this is a similar study looking at the ARCH and FRAME studies. And so ARCH and FRAME used romosozumab as first line, and they're in the green. And then in the orange, this was giving romosozumab after alendronate, and in the blue is after denosumab. And these are BMD changes with hip at the top there and lumbar spine at the bottom. And you can quite clearly see that you see greater increases of bone density in patients who have not had an anti-resorptive first. And I would say just anecdotally that we see this in clinic. So in the patients where I can get them onto an osteoanabolic drug as first line, that gives them greater increase in bone density. You see excellent increases, often similar to what's seen in the clinical trials. If the patients have had a lot of other treatments first, then the bone density increases tend to be not as large, although we don't use this as a reason not to give treatment. So we can see that ideally we give our osteoanabolics first, but how do we choose which one? So firstly, we're going to think about our local guidelines, and my next slide will talk about that. We're going to think obviously about the patient in front of us. Do they have any contraindication to the treatment? And we're also going to think about patient choice. So the sort of things that in clinic patients think about is what's the side effects? How many injections do they have to give? Because these are all injections. They often want to know which is the best drug, and some of them still want to know which is the one that I think or the doctor thinks is the best one. So what do our guidelines in the UK? So let's look at the NICE guidance for our osteoanabolic drugs. So romosozumab is an anti-sclerostin antibody, was appraised by NICE in 2022, and is able for people who've had a major osteoporotic fracture within the last 24 months and are at high risk of fracture. Teriparatide, which is an analogue of the first 34 peptides of parathyroid hormone, is available according to certain T-scores. This is the only one available for men in terms of osteoanabolics. Romosozumab and abaloparatide are not available for men. And abaloparatide has only recently become available towards the end of 2024 and is available for people for women, trans men and non-binary people at very high risk of fracture. So as you can see, I could have a patient in front of me and they might be eligible for one but not the others, and this is one of the discussions that we have. So that's a whistle-stop tour, and I probably could have gone on for much longer, and I've probably left lots of things out, but very happy to take them in questions. But I hope I've signposted you to the current guidance from NICE and NOG. We've looked at how we apply that in terms of screening. And then we've thought about the new concepts of imminent fracture risk, very high fracture risk, and osteoanabolics as first line for osteoporosis. Thank you, and I'm happy to take questions when we reach our question time.